At this moment in myeloma, we have multiple types of immunotherapy, partly available in clinical trials, but also several agents now approved by EMA, by FDA. We have antibodies, we have bispecific antibodies, we have antibody drug conjugates, CAR T cells, and many other types of immunotherapy. So some of these immunotherapies have very specific modes of resistance, but there is also a overlap when it comes to mechanisms of resistance when you look at all these different immunotherapies. And one important general broad resistance mechanism for immunotherapy and also for other types of myeloma therapy is the fact that multiple myeloma can be quite heterogeneous. So multiple myeloma can consist of different subclones. And when you are targeting a specific target, you can get outgrowth of a subclone that lacks that target or lacks that mutation. So clonal heterogeneity, I think, is very important when it comes to resistance. Another important resistance mechanism is the fact that multiple myeloma grows in a microenvironment, in a bone marrow microenvironment, where there is an increase in immune suppressor cells. So there's an increase in regulatory T cells, there's an increase in myeloid-derived suppressor cells, and of regulatory B cells. And those hostile cells, these immune suppressor cells, can also impair activity of CAR T cells, of bispecific antibodies, of monoclonals. And hopefully in the future, we will be able to modulate the activity of these immune suppressor cells. Also in the bone marrow, we have stromal cells. And we and others have shown that stromal cells can also protect myeloma cells against, for example, the CD38 targeting antibody Daratumumab, but stromal cells can also protect cells, myeloma cells, against CAR T cells or bispecific antibodies. So we also need more information how stromal cells confer resistance against this type of new molecules, because that information will lead to better more effective strategies, deeper responses, and hopefully also more durable responses when we know more about these types of resistance mechanisms. And finally, for the CAR T cells, we already know that the characteristics of the T cells that we harvest from the patients are very important. So patients with a lot of naive and memory T cells have better quality CAR T cells as compared to patients with a lot of effector cells and few memory cells. And whether this is also important for bispecific antibodies remains to be seen in clinical trials. Maybe very briefly, something on therapy-specific mechanisms of resistance after having discussed these broad resistance mechanisms. When you have a CD38 targeting antibody, of course, CD38 expression is relevant. And when you are talking about BCMA targeting antibodies, BCMA expression is relevant. And recently, 3 different groups have described biallelic deletions of BCMA gene leading to resistance to BCMA targeting agents, because these cells, these myeloma cells, have lost expression of BCMA totally. So these are more specific types of resistance mechanisms as opposed to the broad resistance mechanisms that I discussed in the beginning of this answer to your question.